Welcome, Dr. Thank you so much, Dr. Good morning, everybody. And I hope, inshallah, to discuss with you on triage, understanding the triage process in pediatric emergency. I know it is a little bit tough topic to cover it in 20 to 30 minutes. Usually we used to do it in 2 days course. But I'll try my best, inshallah, to simplify the process of triage. So I have to disclose that I don't have any conflict of interest. Initially, we're going to cover the introduction, some definition, and histological background of triage. Then we'll go to the process of triage itself. So, as you know, the emergency department are the busy department. You have several cases that came in the emergency. They are ranging from life-threatening to the minor or non-urgent cases. So the effective triage system can ensure the right patient in the right time, at the right level, at the right place, to the right care provider. So what's triage? The term triage is driven from the French word tri, which means to sort. Triage is simply, the term is to sorting or prioritizing the patient or any items if you are using a non-medical term. So history-wise, from where triages began. Initially, triages began in the battlefield under Napoleon surgeon when he is classifying the patient or the soldiers priority to the want care. Then it's come, the term triage is first arising in the World War I in 1940 to 1918. When they are using to prioritizing the soldiers that can be saved to go back to the battlefield again. After that, it's applied in the hospitals. Then it becomes more advanced and more across the improvement and utilizing the resources rather than only prioritizing the patient. So it depends on many categories. And later on in the future, they are now talking about applying the AI and the triaging. The patient will discover, inshallah, covered in the least slide. So how many types of triage we have? We have many types of triage, one of non-disaster and the other disaster triage, which is two different purposes of each of them. In triaging our patient, we are going to focus on non-disaster triage. So when the developing of a triage, there is a main items that can affect the triage, which is the patient characteristic, healthcare setting, and the triage also staff or fact. So emergency department and tertiary hospitals will differ from emergency department in primary or secondary hospitals. So the four main triaging systems that we have is like Canadian CTAS, and Manchester's Australian, and EMS in the United States. So some of them, they are 3 categories, and most of them, they are going with 4 categorizing the patient in 4 categories. Like in the 3 mains, they classify the patient in emergent, urgent, and non-urgent. The advantage is simple to use, but there is too much variability, and too many urgent patients will belong to the urgent categories with no correlation with disposition. In the Australian, they are using the 5 categories. Also, the Manchester triage scales is different from actually the Canadian and Australian, that they are based on algorithm rather than the symptoms and vital signs or other modifier. So they have around 52 separated flow chart depending on the chief complaint. Also, there are 5 levels. The emergency severity index, which used in the United States, is depend on to answering both questions. How soon should I see my patient, and what's the resources that he needs, like imaging or labs or other things like this. Canadian triage, which we're gonna focus on it and we'll talk about it, which would apply in our emergency department in Saudi Arabia. There are 5 categories also: resuscitation, emergent, urgent, less urgent, and non-urgent. So who should do the triage? Is it nursing or physician. Actually, the Emergency Nursing Association recommended that special educated and trained nurse, they can do the triage. Although physician, he might do the triage, but they need to be trained, not only certified as a physician. Also, some skills that need to be in healthcare worker who are applying the triage, like critical thinking, that he can work under pressure. You know, the emergency departments, there are a lot of patients coming in at the rush time, especially in our rush hours. So how he can deal with such patients. So Canadian triage, again, it's 5 levels. Start with resuscitation level 1, which is patient should be seen immediately. There is no delay in resuscitation. Emergent patient, level 2, they should be seen within 15 minutes from arrival. Level 3, which is urgent, should be seen within 30 minutes. And level 4, which is less urgent, should be seen within 60 minutes. And non-urgent, which is level 5, should be seen within 120 minutes. So what's level 1? When we say level 1 is a resuscitation level. Level 1 is applied when there are conditions that are threatening to life, limb, or imminent risk of deterioration required aggressive intervention. Example like cardiac arrest, patient with respiratory failure or arrest, major trauma and shock, and patient with altered level of consciousness of GCS less than 9. So those patients need immediate intervention, otherwise they might arrest. Like an example, 6 years old boy presented with continuous seizures. He is unresponsive, cyanosis required immediate airway management and resuscitation. That patient is considered to be level 1. Emergent patient, which is level 2, any patient with potential to be threatened to life or limb need immediate intervention also, like a patient with shortness of breath and moderate respiratory distress, altered level of consciousness like GCS scores 10 to 13, any neonate with fever who's considered level 2. So, as an example, 7 days old females arrive in ED with a temperature of 39.1 and lethargy. Her vital signs are stable, but patient will consider level 2 because he or she is in unit. Level 3 urgent. Any patient or any condition that potential to progress to a serious problems require immediate intervention. Like mild respiratory distress with shortness of breath, patient with vomiting and mild dehydration, abdominal pain with moderate pain score. Like we say 3 years old, presented to the ED department with complaining of lower quadrant abdominal pain. He indicated that abdominal pain is 5 out of 10, which began getting worse over the last 24 hours. So this patient, we are using the pain modifier, considered as a level 3. Level 4, which is less urgent, condition that related to patient age, distress, or potential for deterioration, or discomfort, mainly. Like a constipation with patients who was complaining of pain, score less than 3 or less than 4, fever with patients who was well-looking, age more than 3 years. Non-urgent, which they are acute but non-urgent condition, like the patient was coming for dressing, for refill medication, some of them they will come for a repeated investigation. All these things that are under category of non-urgent. So to develop standard language to talk about triage, the Canadian Emergency Development Information System, which is CEDS, they developed 17 major categories, which is containing more than 160 chief complaint. You can serve by chief complaint regarding the triage of the patient. Also, triage is not a static process. That means patient may present to the ER with a level 3 or 4, but he might deteriorate to level 2 or below. So triage is not a static process, it's a dynamic process that you need to evaluate your patient. So now, what's the process of triage that we can apply in the emergency department? To start with, the pediatrics triage is different a little bit from adult triage. So pediatric will start with across the room assessment, or what we call BAT, and initial assessment. Second, will screening for infectious diseases. Third, we'll go taking history, and fourth, some physical examination, and the five we have decision, and also if we get some initial management of patient depending on the your emergency protocols or rules. Then at the end, don't forget the reassessment also. So across the room assessment and initial assessment, as we said, we can using the pediatric assessment triangle PAT as we do it in both. So it considers appearance, breathing, and circulation. Any abnormality in one of them or absent, like patient unconscious or patient apneic, sinus, that means patient should go with level 1. Then, as we do in our emergency department, screening for infectious diseases like nowadays for COVID-19, for MERS-CoV, for monkeypox, for children who is coming with skin rash and fevers. So all these patients should be isolated in isolation area. Then pediatric history, triage history, which is subjective assessment. We can use any mnemonic that you have, sample history or CMB's histories, to gathering the information why the patient came to the emergency department. And based on that, we can elaborate more information to determine the level of our patient. Physical assessment, we are using ABCD also, the airway, breathing, circulation, and disability. All these, we are doing it in the vital signs like breathing, we are taking the RR and saturation. And based on that, we can putting our patient in which level. Patient who is setting less than 90 with respiratory distress or failure, for sure they will go for level 1. Those who are setting 94 and above, but they have tachypnea, depending on how much the tachypnea has it related to their age. So will be the level 2 or level 3 or less. So there are modifiers that we can use them in triaging our patient or elaborating more on the symptoms. Like we start first vital signs, then the modifier like the pain, who is presenting with abdominal pain, with aortic pain, you are using the pain scale. Depending on the acute pain or chronic pain, you can decide which level your patient will be on. Mechanism of injury in traumatic patient. It's important to know the mechanism of injury. Is high risk mechanism of injury or low risk? Those patients who fell down from 2 meters will be different to those who fell down from half meters. So although in motor vehicle accident, the type of accident will differ and determine the severity of injury. So patients who's coming walk in an emergency department after trauma doesn't mean that he is well, depending on the risk of or the risk of mechanism of injury. Also, a patient who's with a bleeding disorder like hemophilia or who's using any warfarin or something like that, who are presented with bleeding will be different from patient who was a normal condition. Although we have second order modifier like blood sugar and dehydration status. In adults, we can use also the blood pressure. So, breathing, as we said, patients having severe respiratory distress or respiratory failure with descending less than 90. This patient will apply him as level 1. Patient with mild respiratory distress, setting more than 92, will consider him as a level 3. I will not go into details in each of them because it will be difficult to cover all of them in one lecture. But I'm going to highlight some of them, some important which consider level 1 of each modifier. Again, for C, for hemodynamically, if the patient is in shock, for sure level 1, not a level 2. Yes, I see some nursing, they are applying patient who was in shock as a level 2 because blood pressure is normal. No, please remember that blood pressure is the latest sign for severe shock in children. Level of consciousness, any patient level of consciousness below 9, consider him level 1 because we don't know what's the cause, if he can protect his airway or not. Fever modifier, this is one of the most, let's say, many people confused with the fever modifier. Fever modifier is depending on the age in pediatrics, not like an adult. Any neonate who is less than 3 months or patient who from 0 to less than 3 months, any history of fever they consider to be level 2 and should be seen within 15 minutes as we say. Any patient with fever or immunocompromised also should be seen within 15 minutes as a level 2. Then we can divide them from 3 months to 3 years. If they are well looking or ill looking. Patient with less than 3 years and more than 3 months with ill looking, they are considered to be level 2. But if they are well looking, considered to be level 3. More than 3 years, we are dealing with like an adult. If they are well looking, they will be level 4, and if they are ill looking, they will be level 3. So no patient with fever will consider him a level 5. There are some emergency triaging nurses, they consider patient with flu because he's having cough and dry nose and fever to level 5. No, it's not level 5, it's level 4. Pain, as we said, depending on the severity of the pain and the acuity of the pain. It's chronic or acute. It will start from level 2 till level 5 according to the chronicity and severity of the pain. Bleeding disorder, again, they have advantage on the normal patient. Mechanism of injury, as we said, it depends on the major trauma or general trauma or the head trauma or penetrating trauma like blunt trauma, different trauma according to the mechanism of injury. Blood sugar, as you know, is important and considered one of the vital signs nowadays. Patient will be hypoglycemic or hyperglycemic, different if he's symptomatic or non-symptomatic. Once patient is symptomatic, we'll consider him as a level 2, and non-symptomatic, you can label him as a level 3. Dehydration status, also severe dehydration or shock will be level 1, and patient with mild dehydration will be considered level 3. So after gathering this information and from your patient, you should apply your level of triage. Many times you will see that when I am applying the modifier, some modifier will go with patient level 3 and the other modifier will be level 2. Which one shall I use? We're going to use the lowest triage level. So if he is, let us say with respiratory modifier, the patient will come with level 3. And regarding hemodynamic modifier, patient will be level 2, so we'll choose level 2. Under triage or over triage, under triage we mean that the patient deserve up level, we going him with down. Like patient deserve level 2, we label him as level 3. And over triage is the vice versa. Patient is level 3 and we give him level 2. If you are not sure, my patient, which level is it? Level 3 or level 4? We will go with the worst scenario. We will keep him as a level 3. So over triage is better than under triage. So reassessment, we are triaging the patient, keep him in waiting area. That doesn't mean that we leave him till seen by the physician. We need to reassessment the patient again. So level 1, they are continuous care and continuous assessment. Level 2 should be reassessed with 15 minutes. Again, level 3 with double the time, 30 minutes. Level 4, 60, and level 5, 120 minutes. Also in the triage, especially in the rush hours, patient should be triaged within 10 to 15 minutes from arrival times. So triaging nurse should observe the area. If there are many patients waiting to be triaged, she should ask for help to triaging the patient within 10 to 15 minutes from arrival time. Now, they're talking about the AI in triage. So what's the future direction? They use a hybrid human AI system, which is AI assistant, not replacing the triaging nurse or physician. They are using a large language modules based triage assistant to communicate and prioritizing the patient. There is one studies done found that they decrease the waiting time, average waiting times for the less than 18 minutes. Integration with real-time vital signs monitor, which improve even the prioritizing the patient and decrease the workflow in the nursing or physician that are doing the triage. Expansion, pre-hospital and tele-triage system, which one of them apply for the adults in UK, which is called Voice. They use it for stroke triage, and one other one for trauma patient, which applied in France. They call it trauma matrix. So they are using pre-hospital triage, which is promising nowadays with using AI also with it. The challenges, most of the studies, they are simulation based, is not applied on a real emergency department with full flow. Yeah, I mean, some of them they are only simulation based, and some of them they are applied in certain area in emergency with certain times, not full emergency department. Limited data, also safety and the human override. But AI cannot replace the clinical judgment. Data bias with transparency and outflow integration issue. There's, as you know, ethical and legal regulation uncertainty now. But the research is now talking about the using of AI hybrid with the clinical judgment for that. And yes, there is some promising studies which shows the AI will help us a lot in triaging the patient in the emergency department. Thank you.